New York, Dr. Kodali.
Thank you very much, Gregory and the rest of organizers for inviting me. It's my first time in Athens. It's wonderful to be here. I know that's a pet peeve of his because he mentioned that at dinner last night as well, so it keeps coming up, so I know it's something that we actually discussed quite a bit yesterday. My talk is going to lead into Dr. Mehran's talk afterwards. I'm going to more set the stage than anything else, and so it's sort of, what do we know about stroke at this point? These are my disclosures. I show this slide, but I always tell people we should never use the slides from partner one. And this is really what started the stroke conversation. The reason I show this slide is it's still used a lot. And I want to show it to say that we shouldn't use it. Because partner one was done in 2007, less than 100 TAVRs had been done. It was retroflex 1 with the original sapien valve, and essentially on a Z-Med balloon, no nose cone. So yes, strokes were higher in partner 1 than surgery, but that has been used all the time. And it's been, Hartzell Schaff at that time wrote an editorial which was valid that this is going to limit the applicability of TAVR. Because stroke is one of the most feared complications. If strokes are higher with one therapy or another, that is an important consideration when going forward. But although this data was that it's important to keep in context. This is more than a decade ago with very minimal experience. And I think we have to really talk about the modern era. And strokes have always shown to increase mortality, whether in surgery or in TAVR. And along with bleeding and vascular complications are one of the highest risks for mortality. But what we do see over there, and you see the different devices, and I just focused on the sapien and core valve devices from the randomized trial data. And the neurologic event rates are decreasing. And these are with careful, relatively, people are always going to argue the adjudication of stroke, but this is with pretty close oversight. The current stroke rates in the randomized trials with TAVR devices are between 1 and 3%. And these are all strokes, not major or disabling. These are all strokes. And, there may be some variability across devices. And one of my pet peeves is that the concept earlier, all devices are not the same. The interaction of a device with the annulus is going to be different. And these may result in different event rates across the different devices. And I think we have to look at this and study this a lot more closely. And the stroke rates across the trials have been variable, but this is earlier data, but this is a meta-analysis and saying major stroke rates are around 2.4%. But there's little data, there's some, and as we go forward, there'll be more and more randomized trials, TAVI device one versus another. We'll see a lot more head-to-head data, but we don't have a lot right now. But when you look at sort of the commercial adoption, and we all understand that strokes, anything when it's commercially approved, self-reporting is going to underreport and underestimate the rate. But in the U.S., we have to enter all of our patients to the TVT registry, and the stroke rates are still in that 2.4% range. But what we know about strokes is, most things, vascular complications, bleeding, sort of catastrophic complications such as annular rupture, and those decrease with experience because we learn. And this was an analysis by John Carroll looking at strokes. And what you see is that there's not a learning curve with stroke. It's an unpredictable event. So even in the most experienced hands, it can occur. So it's one of those things we can't teach away. And I think that's one important thing, like other complications. Unlike other complications, there is not a learning curve that goes away. And so when you look at the mechanism of stroke after TAVR, it's just the anatomy is what dictates it. We don't understand all the features of the anatomy, but it's clearly aortic stenosis is a hostile environment. When you look at some of these valves on either pathology or on radiographic specimens, it's surprising that our stroke rates aren't higher. When you look at these things, and I'm sure the surgeons are always so, when they look at it, understand, are surprised why the stroke rates aren't higher with TAVR when you're pushing devices across this environment. And the primary time for stroke is during manipulation of the valve. There's several studies. This was one of the first looking at transcranial Doppler during TAVI. And you see the majority of liberation of embolic debris by transcranial Doppler is either during positioning or expansion of the valve. And that's just different between self-expanding and balloon expandable. And so it's really when you're crossing the valve. It's not crossing the arch, and that's why it's not TF versus TA. It's really about when you cross that bulky valve. And the majority of strokes, more than 90% are ischemic and occur interprocedurally. but there's an increased risk in the perioperative period. When you look, this is just one study again, it's about 50% that are in the first 24, 48 hours, which are probably procedural. The Neurologic has sort of set 72 hours as a procedural stroke, but there's a lot that occur out to the first 30 days. What is the etiology of those events is hard to know for certain. In many of these trials, it's a population where the AFib rates are 30, 40%. They have low EFs, and they have lots of other processes that may account for the stroke, either procedural hypotension, other things. But you have to assume that it's somewhat procedural. Maybe you liberated debris that didn't thrombose or cause an event then, but 3-4 days later it did, or the hemodynamics changed and it did. But they're not all in the first 24 hours. And so some other factors might account for these late events, as we just discussed. Samir in the group has really looked at this extensively. I think one of the advantages of these trials is that we have a lot of data, and this is early data, and we're seeing this more and more, whether you look at partner 1, partner 2, and all these things, that the results are similar. There's this acute phase in the first 24, 48 hours, and then it sort of levels out to the surgical levels. But I think all of these things, all of these stroke analyses are only as good as the assessment. And I think people look at this from trial to trial, and that's why it's really hard to make trial-to-trial comparisons. If you're going to look at one trial versus another, look at what the assessment was. Was it neurologists seeing the patients? Was it the research coordinators doing the NIHS? Or how is the assessment being performed? I think that's important because when you look at studies that use careful neurologic assessment, the stroke rates are much higher. We don't assess that clinically, but when neurologists assess the patient and you do imaging, and when you do imaging, you see a lot higher event rates. So I think it's really important to look at the assessment. And the most common way to assess stroke in a lot of these trials is the NIH stroke scale. And when you look at what areas of the brain the NIH stroke scale assess, this is essentially the components. There's a lot that we don't know and that we're not taking in when we do something as simplified as an NIH stroke scale. There's a lot of cognitive changes that may occur that we're underreporting. And, and when we look at imaging as an assessment, we may overestimate, right? If you look at MRIs, and there's multiple studies looking at MRIs after TAVR, after any sort of interventional procedure, after surgical procedure. But after TAVR, about 2/3 of patients, on average, have MRI abnormalities. Are these real events? Are these, by definition, they're injury? But what does that mean? In other studies, not TAVI, these silent infarcts in sort of medical therapy trials and other things have been shown to increase the risk of future stroke by 2 to 4 times, increase the risk of mortality, dementia, cognitive decline. So these may not be benign, but we can't really assess. In an 85-year-old, who has a lot of these issues, are we going to understand it? That's what's not clear. And then how do we always want to know, okay, well, who's at risk? If the patients care about stroke, can we identify any risk factors? There aren't clear risk factors. Different studies have looked at it, calcium burden, AFib, other risk factors have come out in some trials, but there's no clear risk factor. We've talked about pre-dilatation. Maybe we should avoid manipulating the valve. Again, a bunch of studies. It really doesn't pan out. Maybe for balloon expandable, we should, but it's not clear. But what we do know is event rates are declining. Stroke is an unpredictable event, but the clinical consequences are significant. The majority of patients, that's the complication they fear the most. A lot of them say, I don't care if I'm dead, but I don't want to have a stroke. Because it's lose independence and worsening quality of life. But after surgery, the mechanism of stroke is different. With TAVR, it's manipulation of the valve. With surgery, it's primarily ischemic in nature, but it can be hemorrhagic as well. It can be for either embolic events, but also hyperperfusion. The embolic events can be atheroma liberalized when you cross-clamp, and more probably relevant, when you release the cross-clamp of the aorta, or it could be gaseous emboli. Can also have hyperperfusion and watershed infarcts when patients are on cardiopulmonary bypass. But there are a lot of reasons, and it's multifactorial, and we don't know for certain. But if we're sort of looking at, we're talking about the modern era, what is the data? TAVR versus surgery, what are the stroke rates? And so I put the two sets of randomized trials in intermediate and high risk here. And what you see here in general, this is partner 2A in Certavi in the intermediate risk cohort. The stroke rates were numerically lower, not significant. Certavi was borderline, showing lower stroke rates numerically, but at least equivalent. In the P3 study, the stroke rates were significantly lower with TAVR than surgery. Evolute, they were equivalent. And when you look at disabling stroke, look at these numbers for TAVI, 0 and 0.5%. And a disabling stroke was a modified Rankin score of 2 or higher. So it wasn't, some studies use modified Rankin of 4. So it was not that disabling. So I think this message of stroke being a limitation of TAVI has to go away. I think there's, in the other direction, I think that's one of the benefits of TAVI at this point with the lower stroke rates. So, I think it's very clear now. And what I also want to say, and I know I just said this before, but we have 2,000 patients with pretty close neurologic assessment with the SAPIEN 3 device that show disabling stroke rates of under 1% and on average stroke rates of 2% or less. So I think we have to look at devices across, and they may be different. Is it the manipulation? Is it the crossing profile? Is it less aggressive BAV? And I think as you see new devices, we have to look at the different complication rates. I think those are relevant. In the end, any stroke is unacceptable to a patient, obviously. In a patient, it's 0 or 100%. So if you're having embolic events, why not protect them? And that's what, I'm just setting the stage for Dr. Mehran, but I think it's still a relevant clinical problem if it's happening. It's less so, it's not a limitation of the device, but it's a relevant clinical problem. The question that I'm not sure we'll ever be able to answer is, are these silent microembolic events clinically relevant? And can we improve outcomes with preventing these events? Those are the much harder questions, because I think the reality is they probably are relevant, but we probably need a longer window of follow-up to really assess their relevance, and it's going to be subtle. So I don't know that we'll ever prove that. So, and then can embolic events reducing clinical stroke be enough, and can they do it? We obviously have, ideal deploy, easy to use and deploy that protects all vessels, that really captures all debris and doesn't restrict flow. But the challenge of any stroke and any embolic protection device, it can be a small defect. These are all clinical strokes. It can be a very small defect or a large defect, but it's just about the location. And so you have to prevent all debris from going to the brain. And, and so there's 2 approved devices that Roxanne is going to talk about, but beyond devices, are there other approaches to reducing stroke? We've talked, its focus has been on embolic protection, but what about pharmacology? Can pharmacology change the risk of stroke? And it's hard to imagine that it can, because the reality is, as we said, strokes are embolic with sort of a hostile environment and debris. Valve tissue, calcification, foreign material. This is all the stuff that's been found in filters. 99% of filters in the Sentinel trial had debris. But it's a lot of this tissue, and so can it prevent events? And one question is, if you have a small piece of embolic events, as long as you can wash it through or it doesn't clot off, then it may be relevant. Dr. Dangus has been very involved initially and led the Bravo 3 trial looking at bivalvular versus heparin. We've seen that in the coronary world. It didn't show really any benefit in reducing event rates. What about antiplatelet therapy? We do aspirin and Plavix. That's what the guidelines still recommend in the US as well as Europe, but I think the Europe guidelines are softer. But these are consensus recommendations and not based on rigorous data. The Arte trial looked at it, and the combined endpoint in aspirin and dual antiplatelet showed no benefit, and anything, it showed potential harm. Should we be doing dual antiplatelet? That clearly doesn't impact stroke rate. Then the other thing that we have to look at is what is the role of post-TAVR anticoagulation? The evidence from the registries, we talked about subclinical leaflet thrombosis, suggesting that anticoagulation with NOACs or vitamin K antagonists may reduce thromboembolic events. And so I think that's important to keep in mind. All of these things, it's really about bleeding risk versus thrombosis risk. There's been a couple trials. The Galileo trial looking at rivaroxaban was stopped due to harm in the rivaroxaban group. The Atlantis trial looking at apixaban is ongoing, and we'll get more data. So we'll see the role of anticoagulation as we go forward. But the dilemma of stroke is we all know when it's on the left. What we don't know is where we need to protect. There's injury, yes, and that's obvious, but what's relevant to the patient is somewhere on the left. But what's relevant to a procedure and what we may see long-term may be the entire spectrum, and that's what we have to better understand. And so stroke rates have continued to decline. Recent studies have suggested TAVR has an advantage over SAVR. Embolic protection needs a lot more data, and Roxana is going to go over that. But pharmacologic approaches haven't really shown a reduction in stroke rates with any specific therapy. Thank you very much.
Thank you very much for your enlightening lecture. Anytime I see comparisons of surgical versus TAVI in strokes, always I'm surprised, and I'm looking around and I'm checking with people who is sitting next to me. In this lecture, I asked Greg, I said, you've been for 2 years with us. How many strokes did you see in our service? He said 0. So 2 things happening. Or these 3 and 4 and 2% of surgical strokes are around all the centers, and some centers have more, or centers with high volumes, high experience, 5 anesthesiologists. They don't have these numbers, because if a surgical team has 3% stroke a year and is doing 500 cases, means that we have 15 people that are incapacitated. And this thing doesn't exist. Of course, I cannot prove that because I don't have all these written details and all through CT scans, but we don't detect. Sometimes we do have somebody who doesn't move a hand the next day. This disappears in 2 days. Now, if this is count as a stroke, might, but it's not an incapacitating stroke. So we do still resist the idea of this high number of surgical strokes. And to be honest, equal with our TAVI friends, either there we don't see that many. Initially, when this started 10 years ago, 15 years ago, I thought the half of the valve will go to the left main and the other half in the carotid. This didn't happen. So in both sides, we have encouraging things. Thank you very much.
Sure. No, I think it's true, but I think it's about ascertainment. When we see patients at 30 days, if I'm not in a clinical trial, I'm not doing a careful ascertainment, and so these were all high-volume surgical centers. If you look at the partner and core valve trials, they're all busy surgical centers as well. So and the majority of strokes that you look at were ranking 1 or 0. So they're the ones that I'm not going to even probably notice. If I'm seeing someone for 5 minutes or 10 minutes at 30 days, I'm not going to notice that event. Now, does the fact that they have that event put them at increased risk in the future for other events? I think so. Because all the neurology trials, independent of procedure, have shown that if you have one event, a stroke, you're at risk in the future. So they might have gone through the procedure, but it's still a relevant clinical event. So, I mean, that would be the only point I would make.
No, excellent presentation, Sushil. I also want to make one more point, because we did analyze, as you know, from the partner trial, looking at surgical strokes and TAVR strokes for functional disability. And what we found was that the functional disability was also higher with surgical strokes. So if you look at the major strokes, even the functional outcomes with KCCQ and other functional incapacity were worse with surgical stroke. So it is, even though these numbers are small, these numbers are definitely different and in favor of TAVR. And most patients care, even though it happens in a busy center with 500 valves, it may happen 5 times a year, but 5 times too many. So I think this is definitely a concern in my mind.
And there may be a role for embolic protection in surgery as well, and I think there are trials ongoing. Yeah.
Yeah, that's actually a good point. I just want to extend a little bit the observation. I think it's very correct, the clinical observation by Dr. Patakos, because he introduces a clinical definition, which is not really the major minor. He's actually accurate in what he's saying regarding disabling, which is, in the end of the day, that's what matters to the patient. A lot of the strokes, so the true stroke with MRI positive finding, there may be a quarter anopsia or something like that. I don't know patients even care about that, but it is a stroke, and it's adjudicated sometimes as a significant stroke by both clinicians. This is a stroke perhaps that none would detect unless there is a neurologist. The other aspect is that a minor stroke from imaging can be extremely disabling. If it's a minor pontine stroke, maybe a tiny little thing, and have a hemiplegia or something. So I think we're not exactly there to understand what is the optimal definition for stroke from clinical point of view, but the aspect of disabling is not exactly the same as major stroke. And the disabling part is more patient-oriented endpoint in my mind than the imaging-oriented endpoints that we currently use.
And they're also the ones that have, frontal lobe events, right? That we don't understand, that there's no specific defect. Is that a stroke? Is that personality change from embolic event? All those things are challenging. But in the end, we know that all these events lead to future events, and I think that's an important consideration.
I would argue that we as clinicians should avoid all strokes.
Yeah.
As a patient, I don't care what you say about disabling, non-disabling. I don't want a stroke. No patient wants to have any kind of a cerebral injury. Who wants to leave the operating room or the cath lab or wherever less smart than they entered? I don't think anyone, and I think there are some subtle things that happens within the patient, in patients who have cerebral injury that we do not recognize, nor are we able to capture in a clinical trial, that is absolutely incredibly important to patients, and we have no idea what those are. And I just think that our goal should be to avoid all of these complications at whatever cost, and I think I'm going to talk about the costs, because that is what's holding everyone back, and I'm not sure we have all of the answers, but I think this is sort of our plight. Our real goal and mission is to avoid these important cerebral events.
I completely agree. No debris in the ring, if you can avoid it.
I'll be very brief, because I just realized that this story is quite interesting. Let me give you the example of a patient I had 2 days ago. I operated on him, just a simple bypass, and next day I approach him, next morning, "Hi, Mr. Such and Such, how are you doing?" He was very happy. I said, "What's your name?" I saw him a little bit confused. Said, "Tu." I said, "What's your wife's name?" "Tu." "Which hospital are you in?" "Tu." Moving all four extremities, being happy, grateful, but everything has a name of two. So everybody asked me, "What do you want us to do? A CT scan, an MRI, this, and a neurologist?" I said, "Let's give him a time tincture." 8 hours later, I go back to him again. He's in the hospital, right? We can go and see him. "Hi, Mr. Sacha, how are you doing?" "Oh, very well. What's your name?" Oh, what's your wife?" So 8 hours later, he was fine. So let me submit my ignorance. That ignorance, I said, time tincture. So what this patient had, I really don't know.
Well, Strati, this is the definition of TIA, obviously, and the patients, they do develop minor strokes after surgery. I mean, the number is not zero, and the number is not zero after TAVI. And when they do CTs and they do magnetics, then they discover small, minor, tiny emboli. So there is an issue there. And when you develop a minor brain injury, you don't always develop difficulty in moving your arms or your legs. You don't know how these people behave later, a few months later. So we have to do something to prevent it, and